Good afternoon, folks. Tim Radford here on WKRK 105.5 FM, 1320 AM, cable TV channel 25, and online at WKRK.love. And this segment right now with Dr. Jeff Martin is going to be on Facebook. So good afternoon, Dr. Martin. How are you?
I'm good. How are you doing?
Doing great. Thank you. Well, this is a report with Erlanger Western Carolina Hospital. Dr. Martin, tell us about your practice and how long you've been here in the Murphy, Cherokee County area.
So I've been in practice here for 15 years, almost to the week or the day. My office is over just across from the hospital in the Erlanger campus. I just recently moved to, I think it's Suite D from Suite A, just to have a little more room. Practice has grown through the years, but been here practicing here, and I do some outpatient things up at the Blairsville Hospital as well.
All right. And we got some information, some brochures from the hospital, and some things that were in that brochure that I was looking at, I was unaware of. For example, 1 in 4 men have the leading cause of heart disease as the cause of death for males. Can you expand on that?
Leading cause of death in heart disease?
Heart disease is the leading cause of death, 1 in 4 males. I think I read it backwards the first time.
Well, yeah. I mean, I guess I can certainly. That's I'm a urologist, so I don't see too much or expand on heart disease. But the reality is the overall health of men. Certainly, several years ago there was a study that has to be done for the county health board, which I've been a part of. Just recently came off of that, but. And that's to expand on what types of diseases that we should be focusing on in our current area, and certainly heart disease, obesity, hypertension, and cancer were the leading causes of or leading conditions that we tried to put our focus in terms of prevention. Now, I don't necessarily have much to do with that as a urologist, but certainly we see a lot of patients that have heart disease. And to tie that in with urology, a lot of men that have heart disease also have problems with erectile dysfunction and things of that nature.
And this is an area that a lot of men are uncomfortable talking about too. So this is going to be a program that just it gives all the information, and we, like you said, prevention is so important. And what are some of the lifestyle choices people can make as far as keeping some of these diseases and issues?
Well, I mean, the overwhelming lifestyle choice, which is difficult. If you watch me eat, I don't eat the way I'm preaching, but I mean, certainly a high fiber, low fat diet is been shown to be sort of the standard bearer of what people should try to achieve. Dietary modification is the biggest thing we can do. I mean, and I say this anecdotally with not evidence of medicine, but the reality is that as you age, it is very difficult to exercise enough to keep your weight down and to keep obesity away. I mean, it definitely is way more diet and lifestyle choices than it is exercising. Certainly exercise, we don't poo-poo at all. I think that's a very important part of this, but dietary modification and lifestyle changes are the things that we need to focus on.
What are some regular things that men need to do on a regular basis to ensure their health, or what kind of regular checkups do men need to have?
Well, I'll just speak to urology with that. I mean, I think that in urology, it's recommended that patients, once they reach, there's some debate about regular checkups for urology and blood tests in terms of prostate cancer and things of that nature. However, the American Urological Association does recommend yearly digital rectal exam and yearly PSA starting at age 55 through 69. Once you get beyond that, it's a little more of a choice and not necessarily a recommendation. Prior to that, in individuals, either African American males or men with prior family history of prostate cancer, should get a PSA checked somewhere in the age range of 45, between 45 and 50, and then periodically there until they reach 55, and then it should be a yearly digital rectal exam and a yearly PSA from 55 to 69. And those are the recommendations from a prostate cancer perspective. Okay. Other diseases, in terms of colon cancer and things of that nature, I know that most recommendations would include some type of study, whether it be colonoscopy or a stool sampling or what have you, starting at age 50. And then the recommendation of that would be based on what was found at those tests. But that's not necessarily my specialty, so I'll leave it at that.
All right. How common is cancer in males?
Well, prostate cancer, let's talk a little bit about what I see is prostate cancer, kidney cancer, and bladder cancer. What I mostly see is prostate cancer and bladder cancer, and I'll expand on those. There's been a study that shows that if you took all comers from the time of being born to the time of death, there's a rate of prostate cancer at about 1 in 8 individuals will eventually get diagnosed with prostate cancer. Now, as we've learned more and more about prostate cancer, we've shown that maybe people get over treated for prostate cancer, which can cause more problems than just treating the cancer. So you have to be careful with that. We try not to diagnose prostate cancer in men who have a life expectancy less than 10 years, because the reality is that prostate cancer likely is not going to be the cause of their death. So that, as you reach that 75 to 80 year range, certainly we could probably find more prostate cancer in those men, but do they need to be found? Probably not. Now, in the younger population, the 50 to 60-year-old population, we certainly want to be able to find it and then make the appropriate choice. Some people, even when we find it at a younger age, don't necessarily need active treatment. They just need active surveillance. Okay, and when it comes in terms of prostate cancer. Now, what are the causes of prostate cancer? We don't. I mean, most of the time it just happens, and it's what's called idiopathic, which means we don't have a reason for it or a medical reason. Certainly, family history and genetics do play a part in it. And so, somebody with a family history of prostate cancer, meaning a father, grandfather, brother, certainly need to be aware of that and to be vigilant about getting the appropriate follow-up and screenings that I've talked about. Let's move to bladder cancer. Bladder cancer is primarily a disease that comes from individuals who smoke. It's very rare that you diagnose bladder cancer in an individual that does not smoke or has not been associated to certain dyes or chemicals. A lot of those patients that maybe don't smoke but worked in a in a chemical factory or a plastics industry, or were hairdressers, people that are exposed to dyes or things of that nature. So I think those people certainly are at risk. What are the signs and symptoms of bladder cancer? Blood, painless hematuria, which means blood in the urine without any pain, just seeing blood in the urine. Now, certainly there's other causes of blood in the urine other than cancer, but one needs the necessary workup. If you're urinating blood, you need to be seen to be evaluated by a urologist for that kind of thing. So that's, in a nutshell, or a synopsis, that's bladder cancer. The other cancer that we see is kidney cancer. Kidney cancer, and I just saw an individual today who had no idea that he had kidney cancer, was totally asymptomatic, but had a CAT scan for some other reason and we found a mass on the kidney, or the radiologist found a mass on the kidney that looks suspicious for a kidney cancer, and it certainly, I would concur, certainly is the case. That actually is the most common way that kidney cancer is diagnosed these days. It's usually very asymptomatic, and is only found basically by accident. Now, it does have some signs and symptoms, but usually it's so, before you get symptoms, it's so far progressed, you found it for other reasons. Those would include blood in the urine, occasionally flank pain, but those are the two common things. Now, also, it is very closely associated with smoking. Okay. Now, you don't have to smoke, and the individual I spoke about today, he'd never really smoked in his life. So it's not that, and it's not nearly as strongly associated with kidney cancer as smoking is associated with bladder cancer. Okay. But those are the three cancers that we tend to see the most. Now, in younger, and those happen, probably the bladder and kidney cancer are seen a little more frequently in men than women. Certainly bladder cancer is more frequent in men than women, because as a general rule, there's more men that smoke than women. Okay. Kidney cancer is more equivalent, but there's still a little increased prevalence in men than women. The other cancer that I see occasionally, and it's rare, but is testicular cancer in men. We do see that probably once or twice a year. It's a relatively rare thing. It happens in mostly younger men, almost always in younger men, somewhere less than 40 and between the 20 and 40 age group. It's very rare that you would find a testicular cancer in a man over 50. So that's usually not an age group. And those signs and symptoms basically come with just feeling a mass within the scrotum that's unusual, and sometimes it's painful, sometimes it's not, but is almost always swollen and hard when you examine it.
So what is the reason for the testicular cancer targeting to the younger generation?
Well, most likely it's related to the hormonal milieu within the testis itself, and how those cells are generating and being more, having more cellular activity. Okay, per se. Now, I didn't necessarily mean sexual activity, but just the more cellular activity that would go on within the testicular cell. I don't have a better explanation than that, and that's it's not really known per se, but that's, maybe a hypothesis for that.
All right. You did mention about colon cancer, and a lot of men, as they get older, you were talking about colonoscopies. What's the right age to start keeping that
Well,
under?
I'm not exactly the right person to ask that about, but what I will tell you is that that I'm 50, and it's now time for me to start thinking about that. So 50 is generally without a family history of colon cancer. If you had a family history of colon cancer, there's evidence that states that should be happen a lot earlier than this. But in the general population, I think it's about 50. I don't really want to sound too authoritative with that, because that's not my specialty, and so I don't. But I will tell you, me personally, I start thinking about it at the age of 50.
And we've talked about different kinds of cancers. Is it a one treatment fits all with
No.
chemotherapy, or are they treated differently?
Oh, all the cancers are treated differently. I mean, there's different types of cancer, even when the same organ. For instance, in urology, there is what's called the most common tumor within the kidney is called a renal cell carcinoma. But there's another type of cancer that occurs within the lining of the kidney called urothelial cell carcinoma, or transitional cell carcinoma within the kidney lining, that is treated totally different. So those and even the treatments, the chemotherapies, the recommendations are all different for the different types of cancer. So you certainly can't generalize in that regard.
Well, since you've been practicing for these years, tell me about some of the advances in treatments and technology that you've seen over your span of practice.
Well, I will tell you this. Yeah, that's a good question. You've kind of allowed me to maybe to boast a little bit, but and then digress because when I first moved to Murphy, actually, when I was in residency, treating kidney cancer was treated. We just began treating kidney cancer with laparoscopically. When I was in residency, and actually in 4 different hospitals now, I have done the first laparoscopic nephrectomy, which means removal of a kidney for a kidney cancer. And I did that at Wake Forest as a resident. That was before we started doing laparoscopic treatment for kidney cancers. And then when I got out of residency, we moved. Our first job was in Anderson, South Carolina, and I did it at the hospital there where we took kidneys out, just totally using a camera and making an incision big enough to get your hand in and big enough to get the kidney out. And certainly the advantages of that were less pain, less hospital stay time, and oftentimes less bleeding. And then when we moved to Murphy, and we practiced both here in Murphy and up at Blairsville at Union General, we would do those kidneys that way. But since my time, we've improved that tremendously, even now. And to be quite honest with you, at this point, I rarely do a laparoscopic nephrectomy because we've now moved on to robotic treatment, and robotics has exploded over the last 5 to 7 years. And so basically, anything that you can make a big incision to take out, there is somebody in the world that can take it out robotically. Okay, and so at this time, most of the cancer treatments that's done in terms of removal is done robotically, and therefore I don't do a lot of the nephrectomies anymore because just it's for patient comfort. The technique allows for quicker healing, and there oftentimes there's less blood loss even with that. So we've moved from totally open surgery during my career. When I was a resident, the first few years of residency, we would do gallbladders laparoscopically, and then general surgeons would take out colons. They moved to doing those hand assisted with the laparoscope, and the urologists moved to doing the kidneys laparoscopically, and even bladders laparoscopically, and then now 20 years later we're doing it totally robotic. And you say, well, what does that mean? Well, basically what that means is that they put you on the table. We put trocars into your abdomen in positions that would allow instruments to be placed that are connected to a robot or a computer that allow for fine motor movements so that the robot can suture and cut with scissors. And the surgeon just backs away from the table and goes to a computer and uses a mouse or some sort of joystick to run the instruments that are inside the body. And so tremendous change in how things are done today. It's very rare that I do any open surgery here at Murphy now. Occasionally we will make a cut for something specific, and occasionally patients can't go to the bigger towns, and we'll still do a cancer surgery here open. But we oftentimes do not, because a lot of things are done robotically and with just as good of cancer control and success, with much less recovery time and pain.
I'm trying to wrap my head around the robotic part of that, using a joystick to. So does that improve accuracy?
Pardon me?
Does
Say that
that
again.
improve accuracy?
Well, what it does improve is your fine motor movements. You can, you can. I don't know that you can. I think you can be more precise with where you put a needle and where you make a small nick. Okay, within the. But I don't know that it's grossly more accurate, but it's well, I don't know that it's specifically more accurate, but grossly it may help that. And certainly the fine motor movements of the machine can be dialed in so that there is a very accurate result of where you're wanting to make some change in the tissue.
All right. Here we are in Murphy, North Carolina, 2 hours from Atlanta, Asheville, Knoxville, Chattanooga. So we have healthcare right here. And for the people that may have grown up and said that you have to go to the big city to get healthcare, what has changed over the years that services here are now offered?
Well, I think here at Murphy, certainly, and I don't want to take this because in urology, Dr. Moogerville was here when I was in high school here. So I don't want to take away from him. He's been here for a long time. So urology has had specialty service in this community for a long time. I will say that when I moved here, we moved a lot of that service throughout Union and Fannin counties so that it was available in those counties as well, and not just in Cherokee County. But we have excellent physicians and surgeons here. Orthopedics is here. We have an excellent general surgeon here in Murphy, as well as two excellent general surgeons in Blairsville. I think we also have an ENT facial plastics gentleman here by the name of Dr. Weisenberger, who specializes more in skin diseases and some things like that. Dr. Eichenbaum has been here for several years for ophthalmology. So there's a lot of specialty care that we do have here that other communities may not. Now we do lack cardiology here in Cherokee County, although I know that is quickly coming. Erlanger has committed to put somebody up here, and I think, as a matter of fact, somebody is actually taking over my old office that we just moved out of, and a cardiologist is coming in there. We don't have a neurologist, and we do have oncology care up at Union, well, not at Union General, but just outside their hospital. And there's two excellent oncologists up there that we all here in Murphy use. And even the people in Erlanger refer back after they've had big cancer treatments down there. They will refer them back to those individuals. So I think there's quite a bit of specialty care that's available here. We also have excellent hospitalists in the hospital here now that can take good care of sick patients. We don't necessarily have a tremendous amount of critical care physicians here so there is some referrals that still happen, and certainly with acute cardiac events, those things are sort of an automatic transfer and that kind of thing.
All right. Well, I see our time is coming to an end now. Is there anything that we should have covered that I haven't asked about yet?
Oh, I don't think I think you've covered just general topics pretty well. I guess I would just say that some of the disclaimers, some of the recommendations I may have given in general regarding non-urologic things. Remember, I'm a urologist and not a. I mean, I specialize in urology, and most of the other things are not. That's not what I do. Now, having said that, I probably should put a plug in, because the other thing that I think we have here that I left out is we do have excellent primary care physicians here and have recruited several more. I think you may have recently talked to Dr. Rubendahl, who is new here, but certainly seems to be adapting very well and picking up numbers. And then we also have a new physician, Dr. Davis in Hayesville, and a new physician in Andrews. A couple new physicians. Dr. Sneed's husband and wife team, Dr. Roper and Dr. Mitchell, as well as Dr. Clayton. All have been here for numerous years, much longer than me, practicing, and they're excellent physicians. In Hayesville, as we know, Dr. Hevner and Dr. Jill Brinke are excellent clinicians and take very good care of the patients. So my practice is based on referrals from those guys, and so we definitely need good primary care physicians here, and I think we have added some that will be beneficial to us as we move forward. That is the gatekeeper, okay. And I guess I left out Dr. Brent Davis as an orthopedic surgeon. I don't know if I mentioned him, but certainly he's pretty well known in this community with his joint work and so forth. I think he does a great job with that.
You mentioned that those doctors referred people to you. Can people come straight to you without a referral?
Yeah, yes, sir. I mean, you can call in and see me as a new patient, but primarily they've seen their primary care doctor and they say,
Mhm.
well, this is not, you need something more than what I'm going to prescribe, or what I'm capable of, the information I'm capable of giving you, and then they pass them on, or refer them on. But certainly people can call my office and be seen as a new patient without a referral,
All
that
right.
kind of
What's
thing.
the phone number there?
My phone number, let's see, 828-835-3900.
All right. Dr. Martin, thank you so much for taking time to chat with us and some great information.
Okay. Thanks, Tim.
Have a
All
great
right.
day.
You too. Bye-bye.